Welcome, everyone. My name is Susan Edgman-Levitan, and I'm the Executive Director of the Stokel Center for Primary Care Innovation at Mass General Hospital. And I'm also Vice Chair of the Primary Care Collaborative's Board of Directors. I'm very excited to be moderating this event today, hosted by the Primary Care Collaborative, a national organization that convenes stakeholders from across the healthcare landscape that are committed to improving the nation's health by strengthening primary care, something we all desperately need. I just have to put in a plug for that. So I'm thrilled to welcome you to today's discussion on how primary care can support family caregivers through new caregiver training services now covered by Medicare Part B. A few housekeeping items before we get started. This session, like all PCC webinars, is being recorded. The recording and slides will be posted on our website, thepcc.org. It's a new website that we're very excited about, and it's been redesigned to make it much easier to find outstanding webinars like this one. Today, we'll be taking questions using the Zoom Q&A tool, which is usually found at the bottom of the screen. Panelists will answer questions at the end of the webinar, so please feel free to send questions throughout the entire conversation. The chat has been disabled for viewers, but our team will be providing links to relevant resources throughout the webinar. Also, the PCC is committed to delivering high-quality webinars exploring important topics for the primary care community. We'd appreciate if you take a minute or two after the webinar to fill out the post-webinar survey so that we can ensure that we're meeting that standard. Finally, on behalf of the PCC, I'd like to thank the Commonwealth Fund and Arnold Ventures, whose support has helped to make today's webinar possible. So now it's my turn to introduce our speakers. And we have a wonderful group. All of the speakers today and their respective organizations have been strong advocates. I would say strong is actually not even a strong enough word to describe the advocacy of the people that you're going to be hearing from. For caregivers, and they've contributed to the evidence for investing in caregivers, both to improve their own health and well-being and to enable them to support a loved one in managing his or her care needs. It's hard to overstate the important and undercounted and underappreciated role of unpaid caregivers in carrying out care plans that enable family and other close partners to recover from or manage major illness and chronic conditions. And as Medicare moves to measuring the outcomes of care and experience of care, family caregivers can be key contributors to those outcomes and experiences. And they are often the voice for patients who may not be able to express their own preferences and needs. So with that, we're going to get started. I have to say that I can't imagine that there is anyone on this call today who hasn't been affected by all of the issues around being an unpaid caregiver. And finally, it is thrilling to know that we're beginning to address these challenges for everyone. So before we start today's discussion, I want to introduce our speakers. And you just have to give me just a second here. So we're going to be hearing from Morgan Davin. I was reminded it rhymes with Raven. And Morgan leads the Alzheimer's Association strategy for engagement with health systems and payers, which is increasing timely, equitable access to care and increasing the quality of care for millions of older Americans through partnerships with 400 health systems in the U.S. In 2018, he established the Alzheimer's and Dementia Care ECHO program, which uses interactive case-based learning to help care teams improve person-centered care in primary care and long-term settings. We're also going to be hearing from Alexandra Drain, who is the co-founder and CEO of Archangels, a woman-owned omni-channel platform that engages and supports caregivers across all 50 states through partnerships with employers, consumer brands, health plan systems, communities, and states. And then we'll also be hearing from Nancy Lamont, who serves as AARP's Chief Advocacy and Engagement Officer, driving the organization's social mission on behalf of Americans 50 plus and their families. She leads the organization's government affairs and legislative campaigns and manages their public education programs, community engagement, and volunteer network. And we'll also be hearing from Dr. Peter Holman, who is Chief Medical Officer for Brown Medicine and a member of the Division of Geriatrics. He's been in practice for over 40 years, so he knows what he's talking about. And he's been the medical director of a long-term care hospital, nursing home, and home care agency. So with that, I am going to spotlight Dr. Holman, who is going to provide a very short description of the new Medicare covered caregiver training services to help level set our discussion. Dr. Holman.
Thanks so much for inviting me to participate in this presentation so we can help educate everybody about the services and how they're covered. So I'm a geriatrician. I'm used to seeing patients with caregivers almost universally. I want to give you a little bit of background on the history of some of these codes and talk about some Medicare proposals for the 2025 physician fee schedule, because by the time you get a chance to implement some of these things, we're almost at 2025. So for CPT 2023, the AMA's CPT editorial panel created 2 codes for caregiver training services regarding behavior changes and behavior modification. Medicare elected not to cover those codes for 2023. In 2024, 3 more codes were added by the CPT editorial panel regarding training for activities of daily living and instrumental activities of daily living, sort of functional impairment type of training for caregivers. And Medicare elected to cover those, as well as the behavioral health codes that have been implemented in CPT the previous year. And they said that they would not, however, allow them to be on the telehealth services list. For 2025, Medicare has not only decided that they like these services, that they want to cover them, but they actually created a few of their own services in order to fill in some perceived gaps that probably exist. They created 3 codes. These are for individual and for group services related to caregiver training. That's pretty generic. They use an example of decubitus care and prevention, but it is actually quite generic. And they are going to pay them, we call crosswalking. In other words, they're going to pay them just like codes that are for the ADL and behavioral health. And they also created a behavioral health individual code. These are proposals, so we won't know until around the first week of November whether they're in fact going to be implemented or not. They also propose to put all these services on the telemedicine list. So if telemedicine is going to be covered in 2025, and that may take an act of Congress, but if it's going to be covered, we'll be in good shape there. So one of the first important questions is, what is a caregiver? Well, a caregiver is an adult family member or other individual who has a significant relationship with and provides services supporting that person. And it could be a family member, friend, or neighbor who provides unpaid assistance to a person with a chronic illness or disabling condition. So it is not just anybody. It's not a professional organization that you can contract for these services. Who can report these caregiver training services? They have to be performed by a physician or a non-physician professional, which can include an advanced practice nurse, physician's associate, clinical psychologist, and therapists. In the 2024, so our current fee schedule, Medicare said that it had to be only those folks, but then they added in their FAQs that these are going to be referenced or are referenced in the materials for today's presentation: clinical social workers, marriage and family therapists, and mental health counselors. But these are not services that are provided by clinical staff. So these are not the care management where a nurse care manager who's been trained can provide these services. They are by the individual. And there has to be an individualized treatment plan or therapy plan. So this is not just an educational lecture or a course that you're doing something. This is very specific to the patient or groups of patients at hand. So what are the basic codes and what are the code structures? These are in the materials from Medicare or in the CPT references. So you can I don't expect you to remember the codes, numbers, but 96202, this is the first one. It's a multiple family behavioral management face-to-face with multiple sets of caregivers. And it's a service that's 60 minutes, which in CPT parlance means it has to go at least 31 minutes for you to report it. And it pays per family, $23.70 roughly. Then there's a code for each additional 15 minutes, or again, in the parlance, more than halfway, 8 minutes, and that code pays about $5.50. So those are group codes, so you could have quite a few groups, so it's not $23 for the hour. Then there is the caregiver support services for the ADL and the IDL, including patient safety. Those are written as 30-minute codes, so again, it could be 16 minutes, and that's an individual family caregiver and the clinician, and that's about $53. By the way, the key thing on these is that the patient is not present necessarily. They can be, but they're not necessarily have to be present compared to other services. Then there's an each additional 15-minute code, and then there's also a group code, which doesn't have any time at all, and that pays $22.30. What are a couple of other key features? There must be consent by the patient or their surrogate. Not telehealth today, but we're hopeful that that will be the case in 2025. They can be paid both in the facility, so in other words, a hospital outpatient department, and in a non-facility setting. Now, how are those services reported prior to 2024? Well, frequently, this kind of work has been done as part of an office visit evaluation and management, which works fine for physicians and nurse practitioners and physicians associates, but not for behavioral health clinicians. Health and behavioral assessment and intervention codes have existed, and those can be used by those behavioral health clinicians. And physical therapists and occupational therapists codes can be used. But in all those cases, the patient must be present. So then there have been some services that are performed by those professionals. There are care management services where the patient doesn't need to be present. And then there are care management services that have existed when your staff does the work. In other words, principal care management, principal illness navigation, or chronic care management codes. There's also been paid for in some cases by demonstrations such as the GUIDE program, which is the reimagining of better care for individuals with dementia. And in 2025, Medicare proposes to have a code for advanced primary care. The codes that people select or the use will depend upon the circumstances, whether the patient's present or not, what type of clinician they are, what kind of conditions the patient has, whether it's a group or an individual. And in some cases, these codes may not be used because there is a code that is equally useful, appropriate, and pays more. We don't have any data on 2024 yet. CMS may have it, but it's not publicly available. So we don't know whether these codes are widely used today. Most always, new codes are not widely used. It takes quite a while for people to understand how to use the codes and for them to implement changes in their practice to take full advantage of the services that are in theory available to the Medicare beneficiary as of January 1, 2024. And I think that's why we're here today, is to help everybody understand how to do a better job for our patients and their caregiver family members. Thank you so much.
Thank you. And you just read my mind. How are we going to get the word out, and how will people understand how to use these? So with that in mind, that was a very helpful presentation, and we're now going to be talking with our other panelists about their perspective on what can help make this successful. So I'm going to start with Nancy from AARP, and each of you will have about 3 minutes to respond.
Well, thank you. First of all, thank you for doing this and focusing attention on the family caregiver. I want to take a few minutes to expand a little bit on the description you just had about who is a family caregiver and why this initiative is so important. And then as we move on, we'll drill down on different pieces of it. First off, we've had a lot of conversations about the healthcare workforce. Put this in perspective, there are 48 million family caregivers and 4.7 million paid long-term care workers. So when you think of it, family caregivers are really the ones holding it all together. It's absolutely critical to focus on that as the foundation of our long-term care system in this country. Caregiving, as folks have mentioned, is an unpaid job, and it's an unpaid job that doesn't discriminate by gender, race, age, or any other demographic category. 60% are women, 40% are people of color, 30% are millennials or Gen Z, 20% are 65 or older, and 30% are part of that famous sandwich generation, caring for both a parent and a child. 61% of family caregivers are in the paid workforce, either full or part-time. And this is really important because on average, family caregivers are spending 18 hours a week on care-related tasks. Many of them are taking a step back. 40% told us that they have quit or cut back on their work hours in order to care for a loved one. Think about this. This has tremendous impact on the family budget, and it also has tremendous impact on the larger economy. I can tell you we get almost as many phone calls from businesses as we do from individual family caregivers asking for information. Caregiving tasks run the gamut, and we'll probably talk a little bit about that as we talk about training later. Preparing meals, doing grocery shopping, handling medical appointments, financial matters, but increasingly, family caregivers are being called upon to provide more complicated care for which they need this kind of training. I tell this story often. I was a caregiver at home with paid caregivers and my 2 millennial sons for my husband who had ALS. And he got a feeding tube and a kind of breathing machine early on before he really needed it. When he did need it, we hadn't been trained, and we learned to use it on YouTube. I'm a huge fan of YouTube, but that is probably not the solution to training in the healthcare system. So this is an important matter. I mentioned there are 48 million caregivers today. The demand for, as well as the demands on family caregivers are only going to grow. In 2020, there are more than 55 million Americans over 65. By 2040, that number will be at least 80 million. And tens of million more people are living with chronic conditions like diabetes, arthritis, heart disease, increases in the number of people living with cognitive impairment, dementia, increases in Parkinson's, ALS, and MLS. So we are talking about an explosion of need, much of which is going to fall on the family caregiver. I can go on and on, which for all of your sake, I won't. But the key point here, I think, is this is a tremendously important, previously invisible and unrecognized part of the healthcare system. I believe the family caregiver is the newest, biggest, and least paid provider in the healthcare system. Thank you so much for focusing attention on this today.
Nancy, thank you so much for giving us that overview of the magnitude of the issues here. So we're now going to hear from Morgan from the Alzheimer's Association.
Right. Well, thank you, Susan. This is such an important topic in terms of the caregiver and the well-being and support for the caregiver, and really how can we make sure that our health system in the U.S. is really better integrating the caregiver into the care, especially for people with chronic conditions and particularly people with dementia. And as we're doing that, really paying attention to the needs of the caregiver themselves. So really appreciate what you shared, Nancy, the burden of caregiving and the increased complexity of it. No one should have to go Googling for a YouTube video for the kind of information that they need as a caregiver. Our healthcare system really needs to be providing that proactively. And I'm going to speak a little bit about dementia as a really a particular kind of caregiving need. And Nancy mentioned that with Alzheimer's, dementia, Parkinson's, what that looks like. Nearly half of all the caregivers who provide help to older adults do so for someone living with Alzheimer's disease or other dementia. And compared to caregivers of people without dementia, twice as many caregivers of those with dementia indicate substantial emotional, financial, and physical difficulties. Caregiving is hard period, but there are particular challenges when caregiving for someone with dementia. And those care needs, they do change and they increase as the disease gets worse, as it progresses, and eventually a person living with Alzheimer's or other dementia is going to need 24-hour care. So what does that mean in terms of our health care in the U.S.? Millions of Americans are living with dementia, but far too few of them are receiving consistent and high quality coordinated care. And that leaves many families left to negotiate these complexities on their own, often experiencing poor outcomes. Really, the impact on quality of life, high rates of hospitalization and emergency room visits, as well as significant caregiver stress. So there's definitely a need to address these needs for the caregiver in the community as well as through health systems. At the Alzheimer's Association, we offer a range of caregiver skill building courses, and these include questions to help check the existing knowledge of the caregiver and exercises to apply new learnings directly into their own personal caregiving situations, so that these courses can help the caregiver feel more prepared to handle the challenges that come with caring for somebody living with dementia. One example is this year we launched the Empowered Caregiver Education Program to teach caregivers how to navigate the responsibilities of caring for someone living with dementia. But another important aspect of our work, again, is advocating. I am not a provider. I certainly had experience with members of my family with dementia and what that meant for us as a family in terms of caregiving. But I'm here today talking about our work at the Alzheimer's Association, both with what we provide directly for caregivers and families, and our work with health systems, where a lot of our work is partnering with health systems and advocating with them, so that we need to make sure that with primary care in particular, which is the front lines of dementia care, that we're helping to equip family physicians and other primary care clinicians and their care teams with these resources for their families, and that the payment structures are supporting the delivery of that education and support for caregivers as well.
Thank you. So, Alex.
Oh my God, where do we begin? So first of all, I feel like this is the OGs of care happening right here, because these are folks who, thank you guys. I'm so honored to be part of this crew. I really appreciate the work each of you have done. I love that we all have such different perspectives. I am madly in love with Susan. I have been for years. You have a tireless voice, for which I'm so grateful. I want to cover a couple of things. One, Peter, I'm going to get a tattoo, 96202. I'll let you know when I get it. Thank goodness that we're beginning to see a payment path, because payment paths often make behavior change faster. For all the data that's already been shared, how is it taking this long? Anyone who's been in this role is aware of the impact it's having on us. So two thoughts on that. One, I think there's this phenomenon that happens of othering. Caregivers are really good at othering because they care for others, right? It's always what they're doing for others. And I'm so grateful the system is saying, but you got to start with you. Because if you're not caring for yourself, you will lose your capacity. You literally will. The physical, mental impact is very real. It's very measurable. Nancy, you mentioned there is so many sources of data now on what % of individuals are in this role. RAND, for example, just came out with a study that put it at over 40% of adults are in this role. Archangels has pegged this at 43%. There's so many different ways to define it. The point is, whatever you think it is, it's bigger. And because you're othering, you're probably not seeing it. I would also say the impact on mental health, 70% of us who are in this role have at least one mental health impact. I'm going to give one more data point. I wish I had a warning before I did it, because data can be very scary because it represents humans. 52% of those who are in the sandwich generation role have actively thought about suicide. In this role, actively thought about how to do it. And by the way, 23% of adults, or whatever percent you believe, are sandwich generation. So it's incredibly important for us to recognize we're in this role too. And to the point, to anyone who's listening, I think most of you are listening with your professional hat on, and I love you for that. And thank you for the way that you're showing up on this topic. I'm going to ask you, as you listen to this data, listen for yourself first, Because the first and most important way that we are going to start changing the world is every provider out there, wherever you are in that spectrum, Peter, of all the different people playing these roles. Thank you, Medicare and CMS, for doing this. You're in this role too, most likely. You've probably already gotten at least 5 calls from friends, families, and neighbors today asking you how they navigate the system, what they be doing for their personal life. So I think it's really important for you to be listening. And Erin's going to drop into the chat, if possible, a way for you to get, we call it your intensity score, which is measuring the impact unpaid caregiving is having on you. You got to put your own air mask on first before helping others. Your own self-awareness might help you identify how many folks coming through your doors are in this role. So again, I would just advocate for starting with ourselves first. And one other thing I'll say is, guess what the good news of the bad news is? Employers are starting to care. Why are they starting to care? I like to say it's because they love unpaid caregivers. No, it's because they can't field a healthy workforce. They can't retire, they can't hire, they can't recruit, they can't retain. So the good news for all of us is this has gotten to a size that there's a lot of attention on it. But again, let's start with ourselves, because the data overwhelmingly supports, a huge percent of us are in this role, period. And there is resource to help, like this CBT code.
Alex, thank you. And one quick comment I want to make about a fact that I heard from Alex that I thought was amazing. Some healthcare organizations are now adding questions about, are you a family caregiver? Because people in that role, we know, have the aptitude to care, have empathy, compassion, and help others. And that is actually becoming a screening question for healthcare organizations about who they hire or don't hire, because they understand all of the skills that people in this role develop that they don't even themselves appreciate. So sorry to jump in, but I couldn't help myself.
Yeah,
so
we live in a care economy. This population knows how to care.
Yeah, we're going to move now to a discussion among the panelists. And the first question, I'm going to start with Morgan, is as Medicare rolls out this coverage, what are the top 2 or 3 factors that will determine how successful Medicare and its partners, which is all of us, will be in reaching the caregivers who most need this support and training?
Yeah, thanks, Susan. So first of all, it really has to be feasible in practice and really building it into the practice. I think about all of the challenges and needs in a primary care setting, especially where so much of this really needs to happen. Like so many other things, success depends on being able to integrate this as far as caregiver training, support services into the workflow, optimizing roles within the care team, combined with having a strong community referral network and processes for those referrals, so that we can bring the most help to caregivers and with a manageable burden on the practice. So a lot of that is about flexibility. Care is delivered in so many different settings. Even when we talk about primary care as a setting, there's so much variation in what that actually looks like from one point of care to another. So that flexibility, and that includes how this is paid for and reimbursed. Peter talked about how billing is managed and figuring out what codes are going to work for you and your setting. So being able to have the flexibility for the way your care team is composed, and especially for caregivers for patients with dementia, really important that the care team is skilled in communicating with the caregiver, both for their well-being, just as you were saying, Alex. You have to start with yourself as a caregiver, and the healthcare team needs to be attending to that, as well as really involving that caregiver right from the beginning as an integral part of the care strategy for the patient or the person living with the disease. Again, at the earliest stage, not waiting until the disease progresses and we're at a point of crisis. And then finally, again, for the well-being of the caregiver and their ability to provide good care, measuring their stress and well-being is also important. So Peter mentioned the CMS pilot alternative payment model for dementia care, GUIDE, and GUIDE will include a measure focused on caregiver well-being, and that's a really good start. We need to be really looking at the caregiver's stress and well-being, and we have to measure that to know how we're doing for the caregiver and their role, in support of the patient.
Great, thank you. And actually, I have a question for Peter. Can these trainings be delivered virtually to the unpaid, to the family caregivers? Is that,
Well, today that would be considered a telemedicine visit. So
Yeah.
for the specific codes that I mentioned, it wouldn't be the case today. However, as I also mentioned, a lot of the training currently takes place today either through care management services, which could be a nurse or a care navigator, which, for instance, the guide program uses navigators, or by the clinicians themselves through a telemedicine visit.
okay, thank you. Alex, what would you say about what are the 2 or 3 factors that will make this successful?
Oh, I mean, the healthcare systems has been building resources for years and years and years to help people with things. But if you build it, it does not mean that they will come. So it's so key that we get this new supportive infrastructure out there now that it's getting paid for. So I have a couple thoughts. Number one, start with yourself, right? If the care infrastructure knows that they are in this role, once you see it, you can't unsee it. So many of us are not aware we're doing it. So I think everybody out there in the system has to go through that evaluative process to figure out that they themselves are in this role. Number two, there's this like wide gap between the idea that this makes sense and it actually being implemented and making sense at scale. And part of that is being able to relate to somebody on it. So when you realize it's you, or it was you, or you realize it will be you, you got to start this conversation with somebody. And to start it, talk about your own experience, right? You're going to recognize for somebody before they do, most likely, that they're an unpaid caregiver. And in some cultures, that's not a word they like. And the idea of being recognized in that role actually is something, I'm not a caregiver, I'm just a daughter. And so you got to be ready to roll with however that individual you're caring for is ready to engage on it. So being very sensitive to the language that you're using, I think, is key, and using the current situation as a proof point and sharing your own point, your own reality in it will help feel inclusive. I'm going to give a couple data points. So we support unpaid caregivers who are caring for somebody of any age, obviously, but we're talking about folks caring for someone who's of the Medicare population. I can tell you that 75% of the folks in our data, we have tons of data, who are caring for someone of Medicare age, 2 things are driving their intensity more than anything else. One is not knowing what to expect. So ask that front line of care, the providers, you got to use a hook that somebody cares about. So what you might want to say to somebody as they're in your office is, my guess is you're not exactly sure what to expect right now because things are changing and this is not your paid job. So we're going to talk to you about how you can figure out what to expect. We're going to talk to you about resources. Another is no time for them. Show me an unpaid caregiver who's ever said, I've got plenty of time for me. No, you don't. And so using that as a hook, like what's in it for the unpaid caregiver that's going to make them pay attention to you in that moment so that they take advantage of these resources that you're going to make available for them. So I think thinking out of the box for that, what is that hook, is a really key way that will actually get this out there moving and grooving, which we need in order for it to take hold and become a success.
Alex, can you just quickly say a little bit about what you've learned about how the experience you've had with men who are in caregiving roles and whether they identify as that is actually what they're doing or not?
Yeah, I was actually in a meeting with the CEO of a massive, massive health system just recently. I mean, I've got 8,000 examples of this. And we're in the meeting, we're describing it. I'm in the meeting with this CEO because he understands the impact of his ability to hire or retain his workers because of this other job they have called being an unpaid caregiver. And I'm describing these different examples and we're getting our score together, our intensity score. And all of a sudden he's like, wait a minute, that's me. He's like, every single Sunday, I have to be at the house of my mother. She's 83, Irish Catholic. And I need to be there every afternoon gardening. Now, some people listening would be like, well, that's not care. It is, right? If every Sunday afternoon you are gardening, that's an example of care. Sometimes it's you're the one who's paying the bills. So what we see is anywhere from 40 to 50% of folks who are in this role are men. They are often the least likely to see themselves in this role. And so changing your expectation, Nancy nailed it. Youngers, elders, people who are caring for someone with substance use disorder, whatever it might be. So whatever expectation you have of how a caregiver is going to show up, She's going to be a 53-year-old woman like me, caring for her dad like me. Yes. And there's a much broader population. So again, like throwing out whatever your perspective is, any guy who walks in the door, you should start with the presumption that they're probably responsible for part of this care.
Thank you. Thank you. Peter, the next question I'm going to pose for you is, if you look out 3 years into the future, can you describe an accessible caregiver training service provided in a primary care setting and what that might look like?
Well,
You've been deeply involved in this. Yeah.
Thanks. I think we're all experiencing sort of a lack of physicians going into primary care across the country, and sort of more retirements than people coming in. Thankfully, we're being supplemented by folks like advanced practice nurses and physicians associates, but actually it's really much more than that. We're really looking at integrated professional care that is team-based. I think as we see that changing, we're having a much broader definition of what a primary care practice is like. We're integrating behavioral health. We're using care navigators, community health workers. It's different for everybody. In some parts of the community, it's a solo practice still, maybe with or without a medical assistant. Some people are part of large organizations that have all sorts of support. So I think it's going to vary depending on the type of practice and the types of patients that are being cared for. And some of these services they're not just primary care services. I realize our audience today is primarily focused on primary care, but some of these care management, caregiver training services might be very specialized. They might be around ostomy care, the wound care that was type of thing that was mentioned already. But I think people have been doing this all along. Pediatricians have been teaching new parents how to care for babies, and geriatricians have been helping families deal with, at least in dementia, behavioral issues, etc. So I think it's just continuing to evolve. And what we're going to see, I think, pretty consistently is integrated behavioral health, which will help a lot on the behavioral health training, people being part of the primary care team. I think it'll be quite a while before we see the ADL folks, the PTs, the OTs, the speech being part of a primary care practice, but they may be sort of wraparound type of services to a primary care practice. And I think we're going to see more and more telehealth and people using group visits. Telehealth obviously exploded with the pandemic, and people would never want it to go away. We realize the access it's created. Group visits have always sort of struggled, but I think we'll see more of these types of things going on. These are going to be planned services. This is not going to be sort of an ad hoc, someone comes in and you're going to spend a lot of time with them. This needs to be organized. You're going to address the immediate problem, of course, but we're going to also see them become more and more developed and be part of a regimen the practices want to be prepared to deliver.
Great. Thank you. Nancy, what are your thoughts about this?
Well,
how do you envision this happening in primary care?
Well, I'm the least knowledgeable about primary care system, other than to say that I think this is going to happen in a lot of different settings. I don't know if formal reimbursed training will be in a lot of settings, but I was struck the other day. I went to get my COVID shot, and the pharmacist assistant was talking to a family caregiver and providing some additional information. Mentioned, in fact, that there was going to be training provided by physicians. So I think thinking about all of these different, I know, I was amazed. Thinking about all these different settings where people are engaging, I think is going to be very important. And back to what will make it a success, it has to be clear, understandable, and concise for the average family caregiver. This is not a world where jargon is going to help us. And the family caregiver doesn't need to understand the ins and outs of codes, but needs to understand the ins and outs of what it takes to be a family caregiver. And I think there's a responsibility, obviously, on CMS to make people aware of this, responsibility on the part of providers, those within the system, and a big responsibility, Morgan hinted at this before, for patient groups and consumer groups like ours, to let people know what's available, what it looks like. And I think that'll be hugely important as we move ahead.
Great, thank you. Peter, I'm glad you made the connection to pediatrics, because when Alex was talking about people wanting to know what to expect. It reminded me of anticipatory guidance in pediatrics. And my daughter, who has a 20-month-old, just got some of the most interesting anticipatory guidance. Her pediatrician told her that having a toddler is like having a blender without a lid. And I thought, yes, that's good advice. Take that to heart. So I think, and we hear that a lot with people who are taking care of people with serious illness. What do I expect? How do I prepare? What's scary? What's not, etc. So I think this is going to be profoundly impactful on caregivers. So Nancy, you mentioned CMS. I'd love to hear from you and from Alex about what advice do you have for CMS or Congress as we evolve programs that support caregivers? How can they eliminate barriers and ensure that caregivers are aware of these programs and have access to them?
Well, I'd be remiss if I didn't applaud the important steps CMS has taken in this past year. It was the president's executive order on caregiving about a year and a half ago, but CMS has taken lots of opportunity to see how they can acknowledge and incorporate the family caregiver in Medicare. And I think they are looking at additional areas. We are also working with Congress. You know, it's interesting, over the last 10 years, we've passed over 1,000 bills in 53 states and jurisdictions on family caregiving, whether it's respite care, telehealth, home community-based service, et cetera, and hadn't moved as quickly at the federal level. That's changed, and I think we're looking, obviously, to the important work CMS has taken. We also have a number of bipartisan, bicameral pieces of legislation on the Hill. 2 of them don't cost any money at all. One helps reduce red tape for the family caregiver who, is suddenly thrust into the world of Medicare. Another helps when you call the 1-800 Medicare number, you can be identified as a family caregiver. And then a couple of other pieces of legislation that help with the other big need of a family caregiver, and that is the financial burden. So we are looking at a caregiving tax credit. We're looking at a provision, a piece of legislation where you can use your HSA to cover some of your caregiving expenses in addition to medical expenses. So I think the time has really come, and we appreciate especially CMS and others looking at the full range of challenges of family caregivers. You all have hinted at that or hit it directly today. You know, this is the postseason in baseball. I'm a big baseball fan. So it seems completely appropriate to quote Yogi Berra, who said, baseball is 90% mental and the other half is physical. Let's remember, caregiving is 90% mental and 90% physical, or something very close to it. And having a system that supports that's going to be extraordinarily important.
Great. And I want to second what you just said about CMS. I think CMS is really trying to understand the needs of all the people that they serve and that they provide coverage for in a much more expansive way that I think has really made a difference. So Alex, what do you think about CMS and what they can do?
Peter, right after I get my 96202 tattoo, I'm getting thank you CMS as a tattoo. Because what we find is, although it's been clear for a while, support for unpaid caregivers has to happen. When you start creating a payment mechanism, how many hundreds of millions, billions of dollars have poured into unpaid caregiving in the past year? Everybody keep the faith. Industry is coming, because now that they can make money doing this, they're rolling out every single way that they possibly can to come in here and get these codes utilized so that they can get their piece of the pie too, which is awesome. Because the thing I want to come back to in terms of how do we eliminate barriers, I'll keep going to that notion of what's in it for me, right? The best laid intentions, it doesn't matter if unpaid caregivers are not willing to engage on this topic. And let's be clear, unpaid caregivers have no time. And so thinking about this from the perspective of, this is the way that we market it to the people who are coming into our offices, to whatever site of care it is, has to be sensitive to the insane realities of people's lives right now. And how do we position this in such a way that it's not seen as another task? Now I have this task. If I have to go do training, I don't even have time to eat lunch, right? So how do we be very intentional in the language that we're using? The other thing I'll say, somebody said to me a long time ago, Alex, you really should get active in policy on this caregiving thing. You care. I was like, I don't understand policy. I don't understand policy at all. I've got people like this that I can be like, you guys get the policy. I'll give you the data. Please go make policy happen. And they said, policy is nothing more than people, right? In the end, it's humans. What is driving humans? What's waking them up at night? What's letting them go back to bed? They can go to work. They can't. They get divorced. They don't. They die by suicide. They don't, right? That's what policy ends up following. And whether policy leads the way, or humans or employers who care, or health plans lead the way, the reality of our country, we use the term intensity, caregiver intensity. You're in the green, yellow, or red. Before COVID, 8% of us were in the red. If you're in the red, 90% will have mental health impact. Being in the red, you're there. As of COVID, it tripled to 24%. People thought when COVID was over, would intensity come down across the country? No, it hasn't. In fact, the end of last year, with people being called back to the office, inflation, it went to 30%. At the start of this year, it was more nationwide, around 27%. So still higher than during COVID. So this isn't going anywhere. Intensity, the impact of people on their ability to live their lives and be productive and functioning members of society, which, by the way, the government needs. You can go to work, right? And so someone doesn't end up in the hospital or the emergency room. In the last month, that has crept back up to 29%. We've got to be mindful of what's happening in the world around us right now. Stress of the election, environmental impact. Providers, as you are looking for hooks to talk about this with the unpaid caregivers who are coming through your office, how many of folks are right now worried about if you're caring, like in Florida, intensity is at 33%. So taking advantage, and that's a horrible way to say taking advantage, being mindful and deeply respectful of how very personal it is to be an unpaid caregiver and all the different things that are causing intensity for this individual is your excuse to have that hook to go in and describe why this training is going to be helpful for them. And Susan, if you don't mind, what is the term you coined, that phrase? You did a paper about it. What is that language?
What matters to you?
So
not what is the matter with you, but what matters to you.
So what's going to make a difference? CMS and rolling this out. So we've got to figure out what matters to that unpaid caregiver. What about this training matters to them, and start using that language and get that out there.
Great. Thank you. Peter, I think we have time for a very brief answer to a big question, and that is, do you think that primary care practices that are in value-based arrangements like ACOs or Medicare Advantage are more likely to incorporate this into their practices? Why or why not?
I think they're more likely because I think these services generally are looked at ways to prevent unnecessary, from a medical point of view, not from the needs of meeting the caregiver or the family, but unnecessary visits to the emergency department, which inevitably lead to hospitalizations. There's a lot of preventable things that can be done. People can understand the community resources and things that are available to them. And they're not extraordinarily expensive services. So I think it's more likely that they would be used in value-based payment arrangements.
Great. So now we're going to go to questions that have come in from our participants today. Morgan, the first one is for you. And the question is, I've been a caregiver for aging parents and a spouse diagnosed with Alzheimer's. Will there be educational programs that cover the mental health and self-care for family caregivers as part of this new training support?
Yeah, it's a great question, a really important aspect of this, and there are quite a few caregiving education and training programs out there that do address those. Just as an example, what I mentioned earlier from the Alzheimer's Association, we're addressing many aspects of caregiving, including mental health, well-being, stress, financial aspects, but there are many others as well, not just from the Alzheimer's Association, but there are a lot of resources out there that are really designed for healthcare clinicians and healthcare teams to help use those for education and also for referral, and also directly for the caregiver that they can access themselves. One example, the best programs for caregiving from Benjamin Rose Institute and the Family Caregiver Alliance. That's a great source of information with resources that are organized both for the unpaid caregiver and organized also in a separate view for the healthcare professional. So best programs for caregiving, as well as resources from the Alzheimer's Association and many others. But those are aspects that really do need to be addressed in caregiver education. And fortunately, there are resources for caregiver training and education that address those. We just need to make sure that those are being incorporated into care.
Thank you. Peter, are there any similar initiatives or attention being paid to family caregivers who also need to act as a patient advocate while the patient is in the hospital?
Not that I'm aware of. I think you're talking of these services could be delivered in a facility setting. So in that sense, if you were actually having to train the caregiver on the care behavioral management or ADL assistance or something like that, it might be applicable. But a lot of the training that does go on in the hospital, to the extent that it exists, unfortunately, is not specifically by a code, but it's part of the hospital service that is provided. And some of the education things, for instance, that Morgan just mentioned, are important, but they do have to be directed at the beneficiary. So if you're actually treating the caregiver, you have to do it in a way that it benefits the beneficiary. That's why Medicare didn't initially cover these in 2023, because they needed to see that link.
Okay, thank you.
And Susan, if I may just real quickly on that, I'm really glad that guide does really set a new precedent for CMS, Medicare services. Agree with what you said, Peter. There's also the respite services and caregiver education and support that does start to go a little bit beyond that traditional exclusively for the beneficiary. One other thing I wanted to mention is that question, Susan, I saw that in the chat. That you mentioned, and this is a really important issue as well, that the caregiver really being understood as part of the care, and really appreciated what AARP and clinical leaders like Dr. Kevin Bice, emergency medicine physician, adding to this conversation from what we saw in COVID. Caregivers are not visitors, and that and being excluded from that care and that communication in an emergency room or hospital setting especially is something that we've really got to improve that in terms of how the caregiver is integrated into the care.
Yeah, I think that's really important. Peter, another question for you. Can people in primary care who are care coordinators be involved in this? Many are LPNs or CMAs in healthcare home clinics, and they're doing some of this work already. But are they eligible for this?
So I want to separate always whether we're talking about these specific codes, because I know that was sort of the orientation of this webinar versus important things that are done. So these codes do have to be delivered by those practitioners, physicians, nurse practitioners, or advanced practice nurses, physicians associates, mental health workers, and therapists. However, the physician as a practice can bill for services that are delivered by care coordinators under the care management services or the principal illness navigation, et cetera. So there are ways to include these important members of the care team, and those do not need to be done face-to-face. Those do not need to be done with the beneficiary. So those are payable, but in a different set of codes.
Okay. All right. Thank you. I am just looking quickly through the other questions that have come in and trying to see if there are any that okay. How can Medicare policies be adjusted to ensure more consistent support and financial recognition for family caregivers in primary care settings, particularly in high-need, low-resource communities? And I'll open this up to anybody that wants to take a run at that question. Anyone?
Susan, what does that mean, financial recognition?
I am not sure. I think it may mean coverage, payment, support. I don't know.
I'll take a cut at it. I think
Okay.
the way this is really going to work out best is we recognize and stimulate and support advanced primary care practices. And when that's done, Medicare proposes to do so in the 2025 physician fee schedule for advanced primary care payments. They're going to make $10 per beneficiary per month for people that don't have problems, $50 for those people that do have problems, and $110 for people that are qualified Medicare beneficiaries. So in other words, they're trying to create sort of a health equity type of situation here, as well as recognize the increased resources from a primary care practice that are necessary to care for individuals that are suffering from the inequities that have existed far too long in our society. I think that's really the way to get things done and to recognize a wide range of services. It would also be very helpful if Medicare Advantage plans were required to provide similar levels. They theoretically have to by coverage, but if they don't pay for it, it's not going to get delivered. And Medicare Advantage can choose to pay differently. These codes that I talked about today are not necessarily adopted by commercial plans, by Medicare Advantage plans, etc. And it's important that they do, because a practice has to be there for all their patients by all payers. And if they're going to transform, it really is important that there be a consistent way that things are covered.
Yeah. Thank you.
Susan, I might add one thing too, which is sometimes policies in one area bleed over into another. And there's a lot of energy towards Medicaid right now, and a lot of these populations that the question was referring to. And I think that hopefully practices that are doing a better job recognizing rural, underserved, lower income populations, that the way that they're practicing will be evolving to also be serving Medicare populations. So again, it's that awareness, it's getting out there. And I think a lot of these things will help inform and build on each other, which is great news.
Great. And Alex, I'm going to give you the last word. We have 1 minute, but we have a question about when facilitating caregiver support groups. Some family members are brought in by someone else. Adult children see themselves as the dutiful daughter. How would you help this daughter recognize the role and move forward and get support and that sort of thing?
Yeah.
You've touched on this, but
yeah, I think the key is figuring out, using the language, mirroring back to that daughter, what language that they're using. And that daughter may or may not like the word caregiver, may or may not like the formal saying of this role. So finding what about it is strength-based, I think is incredibly important. And again, I'll come back to being able to say to someone in this role, you have unbelievable skills on this. And this is incredible what you're doing. And what we're trying to do is get you more support, because what you're doing has enormous value in so many ways. So sort of helping somebody go from feeling like they're failing at everything and they're getting no credit, no respect from anyone ever, which is how most unpaid caregivers do, to I see you. And I think what you're doing is tremendous. And you are really helping this individual get along. And my role is to help you get along. Thank you for what you're doing. It can go an unbelievably long way. Most people will start to cry because they'll be like, no one has paid any attention to me at all forever. Wow. Thank you.
Thank you. Well, I think we're at time. This has been an incredibly rich discussion. I think we could be here for the rest of the week, going through all the questions and all the nuances of this. I'm really hoping that this is the beginning of an understanding about how this new support from CMS can be used to support family caregivers. I think it's amazing. I'm actually part of a PCORI grant to provide peer support to parents of children who have who will be on chronic ventilators or chronic tracheostomies. And it's unbelievable because people are sent home basically to set up an ICU in their living room. And I think we have so much more to learn with the evidence about this kind of support, the kinds of safety issues that are arising. It's a whole new frontier that we will need to develop solutions for and support for. So thank you. Thank you for all that all of you do in this arena. And I know we're going to be hearing more about this. So I just want to mention, please The webinar and the recordings and the slides are going to be, we didn't really have any slides, but the recording is going to be on the website, on the new PCC website, thepcc.org. And we also really want you to fill out the evaluation because that helps us improve the way we do these webinars. So thank you. And we'll be sending out the webinar recording tomorrow, and we'll follow up with other details about this and the resources when we do all that. So